similarity is, no matter which concept we are following, in which country, we are going to create a comfortable bite. I'm not going to use very difficult words because we should make it easy. Dentistry is complex enough. So, you go to the office on Monday, your patient comes to me, most of the patients come and they have, most of them, problems in the posterior area. And you're going to prep, you're going to work direct or indirect. You see some restorations, amalgam restoration, some breaking. Pattern here, look at the opening pattern here. We can't continue repairing this stuff. There is something else going on here. So we see daily, look at here. Why these two are broken? Why? We should always ask ourselves, what's going on in the mouth? Just something like this happens. Look at the canine, there is no canine, there is no disclosure. So, in the lab which I work, when the cases come in, first we do the analysis, the functional analysis. Why these are destroyed? Why these are not working well? So most of the people go and directly start to repair, but repairing is not the right way. First we have to find what's the problem. Look at here. I don't know any technicians in the world which finish the bridge like that and send it to the lab. And I don't know any dentist in the world which plants this bridge in the mouth. This happened later. Maybe 1 month later, maybe 2 months later, maybe later. But if you see there is no space, the lower jaw needs space, the patient come back too high. So probably the bite registration was not good. So many of us, when we get the bite digitally or analog in the lab, we're scared. We don't want to call the dentist because we are scared to say to the dentist, your bite registration is not good, because dentist has to call the patient should come back and do it. No. If the registration is not good, you pick up the telephone, you call, the registration is not good, sorry, I can't make it. This is very important. Most of the dentists, if you call them and tell them the bite is not good, I can't make it, they will understand. But if you don't complicate, and later on you send something like this, they will be not happy. So we continue. Here we see also a lot of problems. Say, we can't just make some crowns here. Crowns are not the solution. We have to find out where is the problem. So we slowly go to check the problems in the mouth. Before we start our case, Dr. Edris Bernard. See this, as a dentist, we have some dentists here. As dentists, you see something like this every day. All restorations which are damaged. And something say, should we change it? The patient say, now it's good, it was fine. After damaging, I feel better. So the patients create the comfortable occlusion. Yes, our muscles, our ability, our biology has some pattern. There are studies, Japanese studies. Every day when we wake up, we stand up from our bed with the same movement. We walk with the same movement. We do everything with the same movement because our muscles are programmed to live like that. We are programmed. We don't change it. So our mouth muscles of mastication are programmed as well. So we have to understand the muscles. We have to understand the joints, diagnose and prognose. So our work is not just making ceramics nice mamelons, stains. We are too late. Mamelons and the stains should be the last part. So there are some guidance movements. We should know that. In every case, it doesn't matter if it is a fully rehabilitation after orthogenetic surgery and again ortho, or a single crown. Even making a single crown is more difficult because there is already a system which works very well. Now you're going to put something new in it. You can't disturb the system. That way, making of one crown is more difficult than a fully rehabilitation. So, range of motion, puzzled. We know puzzled, 1952, it's not new. The information which I could give today is nothing is new. We know everything, but we have to use it. Anterior and canine guidance. Canine is very important. In most of the cases, if your skeletal is not a problem, I will explain it shortly, we have to use the canine guidance. Because canines, during the canine guidance, we will not use too much fibers of mastication muscles. So the muscle activity will be decreased. Canine guidance is very important. Posterior inflow. What do we know about the posterior inflow? Our mouth works like a scissor. So when we close the mouth, first we make contact back, then front. So when patients come to the dentist and say, the 6 front teeth of me are not nice, I want veneers. We have always to look back. What is the posterior condition? And most of the time you see the condition of posterior is even worse, but they don't see it. So we have to start from back to the front, always. And this is what we do in our environment in Holland, in the Netherlands. So, upper jaw is fixed to the skull, doesn't move. So most of us, when we work with articulator, we do like that. This is wrong, because upper jaw is glued to the skull. So we have to take the articulator from above and open it like that, because our lower jaw is moving, not upper jaw. You're like that. We eat like that, from left to right, or right from left. And this camel needs to go to the orthodontist, probably. But it's very important to find out, are we dealing with a vertical chewer or horizontal chewer? Because the concept will change. A vertical chewer is not that difficult. But the moment the patient, because of the dysfunction or parafunction or whatever, doesn't have the regular pattern, then the case will be difficult. So we determine the canine guidance, vertical or horizontal chewer, and after we know that, we can start with the case. So this is very important. That way I ask my dentist to register the bite by occlusion paper, blue or red, to see the movement. So this movement is necessary to understand, to manage when you create occlusion. Because when we make restoration, you're creating occlusion. And occlusion is very complex. That way we need a lot of information in order to create the comfortable occlusion. Look at here, a lot of forces. We learn all at the School of Dentistry, the contact, the static occlusion are dots, not movement ranks. You see, we don't see any dots. So it means the lower jaw, or the muscles of mastication, the lateral pterygoid muscle is constantly in search to find the comfort zone, and they can't find the comfort zone. Look at the cracks here. One crack, here a crack. All the cracks are because of too much forces. Our natural teeth start to break. And what we're gonna do, we prep it a little bit, use some composite or some lithium disilicate, or if you want that the crown is very strong, you go for zirconia. Zirconia is the wrongest material. So what happens to the muscles? The muscles have some obstacles, you make it even stronger. So the muscle activities will increase. We have to decrease the muscle activities. If somebody works like this, you can't hold it. It will be more difficult. So we have to decrease the muscle activities. So let's start with some very important and crucial points. Centric relationship, CR. CR has nothing to do with the teeth. Nothing. There is a range of, there is somewhere we are going to find it out. And we are going to see also what is the fully seated condyle position. This is the fossa, is the glenoid fossa and condyle head. Where is condyle? Nobody knows. Where is the condition of the condyle? Where is the condition of fossa? What is the condition of discus? They are very important information. If we don't know, we do mistakes. So, the movement should be repeatable, and lateral pterygoid muscle is releases. I'm going to explain to you. So, we have to understand the muscles of mastication and the anatomy of that, the condition, the joints. Joints are very, very important. The anatomy and condition of the condyle, discus, of course, very important. Fossa, anatomy of mandible, genetic, and all the information. So, before starting the case, we also, as a technician, have to understand some very important information about anatomy, because anatomy is not, the problems are not always on the tooth level. The problems are somewhere else. So we have to understand where is the problem from. We have to understand, to learn, and see how is the position and condition of the, of the condyle head. Look at here, counting here is very small. So if you're interested about the whole paper or study, please make a picture of the text, because then you can find the paper. Most of the patients which are in the normal position, they don't come to the dentist because they have comfortable bite, everything is fine, they don't visit the dentist. So most of the time when they are in flattening or erosion, they come to dentist. And you don't look at the mouth, you don't look at the joints, you just take the bite registration and send it to the lab, and lab make crowns. And 95% of those labs, crowns are wrong. And the 5% which is good, you were lucky. And we can't base our work on luck. We have to understand what we are doing. You also need to understand what is the condition of the discus. How is the movement of the discus during the mastication movement? So there are studies, there is a lot of literature. If we don't use all this literature information, we bring us to the danger to make mistakes. So the Bennett shift, the Bennett angle, what are those? Of course we had it at school, but we forget about it as soon as possible. No, they are very important. And nowadays with the digital dentistry which we have done together, you can see how important are this information. Anatomy, the photography, why photography? Why sagittal view? Sagittal view is very important. If you ask your orthodontist why you look at the X-ray at the sagittal view, because they explain you, I'm going to check how is the condition skeletal. Is it a skeletal compensation or dental compensation? You can measure everything. You have the armed through vertical line, you can see the angles. All these small details give us information about the condition, anatomy, and health of the upper and lower jaw. And then we start to find the environment which are working it. Is it a healthy environment or not healthy? We can't do the same thing every day for everybody. We should customize our thinking and also our work. Dental or skeletal problems. So, there's a very important muscle which is moving the lower jaw in, let's say, forward, superior head and inferior head. One of them is supporting the lower jaw to move forward, and the other one stabilize it. Very important, this is occlusion. The puzzle, which we know, is this. The points, what we see in the mouth, is this. So if you don't understand this, the rest will be also wrong. So every case which come to us, before we start doing any wax up, any DSD, we finalize it here. We define what are the problems, because it's a system. We have the muscles, we have the central nervous system here in our head. We have the muscles, we have the occlusion, and the teeth, they are like sensors. If the pain is too much, teeth will move, they can rotate, they can come out of the comfort zone. So we need to analyze everything before we start doing the case. Some small movements, centric, first contact tick, and then the lower jaw moves forward. Look at the lateral pterygoid, which contracts and moves the lower jaw front. So we have the first contact, this the retruded contact position, or RCP. In America they call it CO, centric occlusion. Then we have ICP, intercuspal contact position. So from RCP to ICP, in between there is a shift. The bigger the shift, the bigger trauma and the bigger problem for us. So that's why we have to define, is there shift? Is the shift to the left or to the right or to the front, or the combination of those? Progressive side shift. The lower jaw is programmed to move like that because our muscles know the obstacles in our mouth. All of us, 90% of us, have occlusion problems. But our muscles know, okay, there and there are some obstacles. The cusp are too high. I don't want to hit them. I want to close like that in every mouth. So we have to find it. So we have also the fully seated contact position. We were talking about it. First contact, centric occlusion, shift to the maximum intercuspal position. And if you are very creative and we make very nice anatomy with very nice cusps, and the cusp is in the shift, you increase the muscle activities, which is not good. That way we have always to analyze the occlusion. How will occlusion look like? If the occlusion is flattened, we can't make nice anatomy because it doesn't work. The mouth tells us a lot of information, but we have to open our eyes and mind and read it. And we have also end-to-end occlusion front. This is not for today because I don't have the time for it. Okay, this is very important. Make a picture of that. So we see some problems based on that what we see in the mouth on the tooth level. But there are also some problems which are in the joint levels, which we don't see. We need CBCT and MRI to see the condition of the soft tissue. MRI is for soft tissue and CBCT is for hard tissue. So, and finally we are going to create a tripod concept. So stabilization at the condyles and one point somewhere, and in between we can make the teeth. Then you're fine. Then you're fine. And this is the moment that when we start provisionals. Because sometimes even you're very good and your dentist is very good, it is a moment patient come to the office for maybe 20 minutes, half an hour for bite registration. Maybe patient is happy or sad or has pain or didn't sleep well. So the condition of the muscles define the movement of the lower jaw. Good. Let's start with this lady. She came at 2014 to the office. We have done some pictures. Photography is very important. Collins syndrome. This formation of the lower jaw, underdeveloped of the lower jaw, and she's missing the development of the bones in the facial. So many problems. She had some surgery in order to fix the problems. I don't go into the details because we need about 4 days. We did it together 2 days, the presentation. So let's look at the CBCT scan. It gives us a lot of information. So this is the condition of the patient, of course, the first moment. This is the digital dentistry in the world, so we need to use all the digital devices, what we have, in order to look inside. So, this is a good patient. Why is she good? She was taking care of her mouth. She went to the dentist. She made crowns. Of course, we see the crossbite. We see the lower jaw, which is still growing up, eruption, and we see she has some restrictions. She doesn't have the movement. Left and right side. So she needed some surgeries. And okay, very important picture. Look at the upper jaw. Very small, deep palatum. So we see that she has no space for breathing, for chewing. And what is interesting, what we did during the analysis is the cephalometric. Dr. Edris has been trained also in orthodontic way of thinking. So she used her softwares and put all the information to find out if we can fix it orthodontically. This is the first option always, because the teeth are not in the right place, so we have to move them to the right place. The maxilla, the bones are not at the right place, so we need to open the space. So with orthodontic treatment, we can do a lot. So we measure everything. We consulted with 2 very good orthodontists, and they said she has very short roots. We can't do any orthodontic treatment. So you need to do it restoratively. So now our problem is big because we have a not healthy environment, we don't have enough space, and we have to fix it. It's very difficult. That's why we need all the information about the muscles and occlusion. So first, we are going to find the centric, as I said. You don't want to work in the shift, you want to work in the rotational movement. Yes, centric. So she used the coist deprogrammer, and it was difficult. How long did you need to deprogram the lateral pterygoid muscle? 2.5 months. So